August 28th meeting, and this is the third meeting of the Interim Joint Committee on Health Services this summer, and we've got a great agenda today, so we will go ahead and take the roll.
Senator Rocky Adams, Senator Chambers Armstrong, Senator Berg, Senator Carroll,
Here.
Senator Douglas,
Present.
Senator Elkins, Senator Funky Fromeyer, Senator Nemes,
Present.
Senator Tishner, Senator Wise, Representative Bentley, Representative Bratcher, Representative Bray, Representative Burke, Representative Callaway,
Present.
Representative Camule,
Here.
Representative Dotson, Representative Duvall,
Here.
Representative Fraser Gordon, Representative Justice, Representative Neighbors,
Here.
Representative Rayburn, Representative Raymer,
Here.
Representative Riley, Representative Works, Representative Sharp,
Present.
Representative Wilner,
Here.
Representative Witten,
Here.
Co-Chair Meredith,
Present.
Chairwoman Mosier.
I am here. We have a quorum established to do business, so again, welcome everyone. I'd like to entertain a motion to approve the minutes from the July meeting. We have a motion
Second.
and a second. All in favor, please say aye.
Aye.
All right, any opposed? Thank you. The minutes are approved. The first item on our agenda, we would like to talk about the collaborative care model regarding psychiatric care here in Kentucky. And we have Dr. Robert Caudle, online, and Dr. Leslie Aslam is here in person. So if you could please make your way to the table. Invite any guests if you have any. No takers? All right. Well, welcome. Thank you. Please introduce yourselves for the record and make sure that your green light is on so that we can hear you. And thanks for being here. The floor is yours when you're ready.
Good morning.
Microphone. No, is the green light on?
It is now.
There you go.
Okay. Good morning. Thanks for having me. I timed what I wanted to say last night, and it was 21 minutes, so we're not even going to use slides. I might refer to them, but we're just going to kind of zip through it. My name is Leslie Aslam. I am the Director of Behavioral Health at Sterling Healthcare, based in Mount Sterling. There we go. Oh, I moved this. We serve Nicholas, Bourbon, Bath, Clark, Montgomery, and Powell counties. We have primary care, we have behavioral health, we have a range of services you guys can read. I was hoping to kind of all maybe agree on three things before we go forward, just for the sake of expediency. So number one, our population, nationwide, statewide, we are in the midst of a mental health crisis. Maybe a show of nods. We all kind of agree with that. Yeah, it's bad out there. Number two, there are not enough behavioral health providers, so therapists, prescribers, so psychiatrists, psychiatric nurse practitioners. There are not enough of us to meet the needs of our behavioral health crisis. Everyone sort of agree with that too? Yes, it's an issue. And then number three, we are also seeing kind of record high burnout rates among primary care providers. So primary care is the backbone of our system. They are burned out like we've never seen. I could expand so much on this, but I don't have time. But do we all kind of agree that primary care is having, they're kind of on the struggle bus? All right. So I did med school at UK, and then I did a triple board residency that is pediatrics, adult psychiatry, and then child and adolescent psychiatry. And after residency, I joined Sterling Health because they were genuinely interested in holistic whole person care, integrating mental health care into primary care, which as a pediatrician also, that is important to me. You cannot separate the two. So in preparation for this talk, I chatted with a bunch of my friends who are still in primary care. They're not well, by the way. I'll quote one of them. I can teach my patient how to manage his diabetes, but is he really going to eat better and exercise and check his blood sugar and take his insulin when he doesn't even care if he wakes up? How do I address that in 15 minutes? And one thing I would just want to put in all of your minds is that it's actually the most compassionate primary care providers who are the most vulnerable to burnout, because they're the ones, getting those last minute bombshells like, oh, by the way, since my wife died, I've thought about nothing else but joining her. Or the kids at school are so mean, I wish I was never born. Those are the things it's always invariably as you're stepping out the door that you're like, man. So it's the compassionate providers who get stuck trying to manage those huge concerns in 15 minutes, along with all of the other things that primary care has to manage. And it's simply too much. So at Sterling Health, we have addressed this by, I wouldn't say integrated mental health care. I would love that, but we're not. I would say that we are co-located with benefits. What that means is that when you get this bombshell dropped on you, or you simply screen for depression, find it's quite elevated, talk to the patient, and yes, they're struggling. They need services. What our primary care providers have the option of doing is offering primary care to our behavioral health care to our patients. They say, hey, we've got therapists who work in this office. Rebecca's office is right there. You've seen her toys. We've got prescribers that can help you. How about you fill out this packet and then we'll get the process started. Patient fills out a packet. It's something that we actually borrowed from Intermountain Health in Utah. I don't know if you're familiar with them, but it's basically a compilation of validated screeners, an assessment of your mental health treatment history, just so we can get an idea of kind of the acuity level of your needs. And then what I think is really cool is that at Sterling Health, once per week, every primary care provider meets with me. We have what's called a care conference, and they join via Zoom. We talk about all the referrals from the previous week. We go through what the packet showed. They tell us what they know about the family. It's a chance for all of the providers seeing this patient to actually communicate face to face, which really makes a big difference, like a warm handoff. Once we kind of triage the acuity level, not every patient needs to see a psychiatric prescriber. Maybe they've never even tried a medicine before. So we'll get them in with a therapist, but in the meantime, I consultatively manage with the primary care providers. So, that helps enable them and empower them to pick off some of that low-hanging fruit. This patient's never tried any psychiatric medicines. Start some Prozac. Let me know how that goes. We'll check back in 4 weeks. And I keep a list of all the patients that I kind of co-manage with the different primary care providers. And they feel very supported in doing this. Most of them have really come a long way in their psychiatric prescribing, I'm proud to say. I'm trying to teach myself into obsolescence. But it allows us to kind of go on, ongoingly manage patients and ideally meet them where they are, meet their needs. I know I'm short on time. So the big thing I want to point out is that behavioral health care simply takes more time. It takes more time than primary care providers are able to spend. They have those 15-minute visit slots. They've got to keep moving. It's the compassionate providers who are the most behind. So what are we doing in those sessions? We're teaching coping skills. Have you ever tried to teach a feral 4-year-old how to do breathing exercises? It's not easy. You have to sit and be patient, repeat it like 10 times. A big thing for me is that diagnostic clarity is key. It is essential. You can actually do harm in psychiatry if you don't know what you're treating. For instance, a common one that I see is people with what's actually bipolar depression. If you don't know the right questions to ask, you just think it's a good old-fashioned unipolar depression. You want them to get better quick, so you start a nice high dose of, an SSRI, and then all of a sudden they're manic. Oopsies, you can do harm in psychiatry. So that first intake appointment, mine are 90 minutes, guys. Like, I spend a long time with the patient to really develop trust, get them invested in treatment, and then also figure out what I'm treating. So by the end of that 90 minutes, I kind of know what's my first, second, third line, and then I can get them stabilized and then send them back to their primary care. Once they've, if I've not made med changes for 2 visits, you don't need to see me. So we are trying to, in integrating mental health into primary care, it helps address our mental health crisis because obviously we need access, but it also helps expand on the limited resources we have, right? So I don't need to be seeing every patient who's on Prozac. I need to be seeing the highest acuity, most difficult patients with a long psychiatric history. And I need to enable my primary care providers to kind of keep those lower acuity, mild to moderate patients. This is the support that PCPs really need. It's what they want. They do we have pretty good retention at Sterling Health because they feel supported to deal with these difficult issues. And I will just put out there for you guys that these long visits mean that we don't reimburse really well. So it has to be prioritized. Thank you.
Wow, thank you.
That was quick.
That was quick, but it was really, that was a great overview. So I think we all clearly understand the need, and we understand, for the most part, what you do. I love this model. I think it's very needed. It's very, just creates all sorts of efficiencies for everyone involved, especially in light of our workforce challenges, our high need in Kentucky and across the nation. So thank you for what you're doing. And I think, Dr. Cottle, are you online with us? I'd invite you to share your thoughts. Okay. Technology. Okay. Well, while we wait for Dr. Cottle to be able to join us, we're working on some technical glitches here. I just maybe he was going to cover this. I don't know. What are the challenges that you're seeing in integrating behavioral health into this model?
Sure. Well, one issue is that with longer appointment times, so Sterling Healthcare is a federally qualified health center. We bill with, the RAP rate, we get a PPS rate. So if I spend 90 minutes with the patient, that's 6 visits for a primary care provider. And we bill, so they're running circles around me in terms of what they reimburse for. It's just the truth. So you basically have to organizationally make a commitment to saying like, look, behavioral health services are not going to be, terribly profitable, but the cost of untreated mental health, I argue, is vast. Participation in the workforce, ability to attend school, basically all of your general functioning depends on how your mental health is doing. If you are a mess, you're not going to work, you're barely bathing. So to me, it's also really important to help support our primary care. So that's kind of where we get around it. But smaller organizations that are looking to do it right, when they look at the numbers, it's not terribly profitable to offer mental health services.
So is this a bundled rate that you're
Correct.
proposing? Okay. And how's that being received by MCOs, or have you gotten, clearly you're practicing, so you've figured out something.
Well, so yeah, we get the RAP rate, basically we get the PPS. So what basically we distribute it out. So we see enough primary care visits that it pays for us to be able to offer behavioral health. I guess that answers your question.
It does. Yeah.
Okay.
All right. Dr. Cottle is on, so I invite you to join us and give us your thoughts. Thanks for being here today.
Thank you. I'm here to speak mostly about the collaborative care model. I don't know how familiar everyone is with that. So did I miss anything? Is that something everyone's very knowledgeable about, or would you like a quick presentation on that?
I think that you can give us a quick overview, but I think heard about the collaborative care model. So
Okay.
yeah.
Then very well. I'll just kind of jump to it. It's sort of a formalization of what used to be curbside consults. It's a way to extend the workforce in mental health in Kentucky and other places as well. It was proposed by the American Psychiatric Association about 10 or 15 years ago, and a number of states have already adopted payer mechanisms so to get it reimbursable. But basically, it's population care, which is moving away a little bit from the older model, which is not defunct or anything, but it's just a very efficient way to provide a higher level of expertise than would ordinarily be available. Some of you may be familiar with something known as Project Echo that was done in the state a number of years ago. It was a way to sort of get expertise out of academic centers, for instance, into more isolated areas, and it was fairly effective in that regard. This would have a similar effect in that it's a force multiplier. It really does bring a high level of mental health expertise to a large group of patients who otherwise would not have such access. So as you may or may not know, I guess my interest in my work in academia has been mostly around telehealth. And the word that we've always used from the get-go is access. How do we get more access? And I think collaborative care is certainly a way to achieve that. So hopefully we can just follow the model set by many other states and enact whatever sorts of, I'm not the legislative wonk, so that piece, you lose me, but I can sort of tell you from a clinical standpoint, it makes a lot of sense. And we'd love to get it going here. The large systems of care will be the easiest place to roll it out first, but eventually pretty much any small primary care site could potentially be a receiving end of this sort of thing.
Okay, thank you so much. We do have a few questions from our committee members. Senator Adams.
Thank you, Madam Chair. I was interested in the exact same thing that you just asked about, the payment model. And I understand what you're saying, that the compassionate providers are the ones that kind of lose out. So if we wanted to bring this model to Kentucky, I know you're kind of doing it now. Does it have to be formalized in any way? Have we talked to the cabinet? Does it require legislation? Like, how do we kind of make that? Okay.
Sorry, hi, I'm Molly Lewis with the Kentucky Primary Care Association.
Can you turn on your microphone, please, and do that again?
Oh, yeah, thanks. Hi, Molly Lewis, Kentucky Primary Care Association. So what Dr. Aslam described is basically the reality of what's necessary to take care of the patient, but the way that currently this model of the collaborative care model has an opportunity to be reimbursed, and it actually can be reimbursed at a PPS rate where all of the behind the scenes part of Leslie supporting the primary care doctors in doing it could actually generate another claim, but currently we're not in a position where we can do that. And so I think that that's part of the proposition. Because it requires...
And keep following along that path, which is, how do we get that?
Well, I mean...
Is it legislative?
Yeah,
or
it's
is
legislative.
It...
So it's
Okay.
something to be a covered service by the
Okay.
Department for Medicaid Service. And the way that it would work is that it does require intensive documentation because it involves, how the psychiatrist or the primary care supports the peer support specialist in that huddle to get ready for the meeting, and that individual as a peer support specialist providing that extra layer of support, and actually whole team working at the top of their licensure. And so those components of this model end up generating a CCM claim.
Okay.
And then that claim would be submitted for reimbursement. But currently,
It's way too labor intensive.
it's too much.
It's just not worth it to
Okay.
us, so we just eat the cost.
Okay. Thank you. And thank you, Madam Chair.
Yes, thank you. Senator Funky Fromeyer.
Thank you. Kind of following along, I don't fully understand the acronyms, but you talked about the wrap rate and the PPS. So I wanted to try to better understand that. But I also was a little bit surprised because you were talking about sort of a prescription that involved a psychoactive drug. Is there some potential, and I think about health coaching for a second, you mentioned nutrition, you mentioned exercise, but also sleep,
Oh, yeah.
because we recognize sleep is
So lifestyle medicine, you should check into that. It's excellent. It's basically, but all of that takes time. Coaching takes time. You have to have long appointments with these patients.
Forgive me for just 1 second.
Sure.
So coming back to the model that I follow,
Right.
but it's about a monthly, and it's about 12 minutes just checking in to see how I've done on this tracking of where's my nutrition, where's my exercise,
Sure.
and where's my sleep, and making a few adjustments. But I'm wondering, is this something that you can then bill? You were talking about the different codes, but even bill at that most acute mentally unhealthy person on a weekly basis to get them through that acute stage and celebrate, all right, you've done, and do you send them out of your office with a tracker? You've done 20,000 steps a day. You're getting out and about. You're doing the hard things. You're actually
Right.
and you've read nutrition labels. You're not having the heavy sugar intake. I personally recognize, and it's taken me a journey, but that you almost need that accountability coach.
Right.
Are we reimbursing you for those accountability coaching that I think is needed?
No, not really. We kind of depend on our therapist to do that during visits, but when they're only meeting,
basically you kind of come and go out in therapy as you need to. So we've sort of used peer support specialists as almost like therapy extenders. They do little warm touches with the patient between visits. Just
How frequently?
depends on the patient and kind of where they are in their course. But yes, I'm very into. Ironically, I'm a prescriber who doesn't actually love psychiatric medicines. I really try to use the least amount possible, lowest dose possible. Try to look for the natural, normal things that tend to exacerbate mental health issues, and get those. And then at the end of the day, some people have organic illness that needs medication, but ferreting that out is part of the fun. Like that's what we enjoy doing, and trying to get people just functioning at the top of their abilities.
Okay, thank you. Representative Wilner.
Thank you, Madam Chairman. Thank you for the presentation. This is a really important topic. You mentioned that you're using like co-location with benefits, and as long as we're going to try to move in the right direction, could you say a little bit about what full integrated health would look like and what the barriers are there? Why don't we go for that?
Right. So full mental health integration, it utilizes provider types like behavioral health consultants who basically don't have a block, a schedule. Their whole schedule is open. And the moment that a primary care provider is discovering like, oh gosh, you're really struggling, let's have you come talk to Tom. Tom, come on over here and talk with this person. We don't have the ability to just block provider schedules for a whole day and not have them seeing patients and billing, because we can't afford it. But once you fully integrate mental health, you do have the ability to have positions like that. They are billable in certain states and certain models, but we don't currently have it structured that way. So again, it all comes frankly down to money. But those people are also like, they're not only for mental health issues. Let's say that like, man, your A1C just keeps creeping up. That's a measure of blood sugar for diabetes. This is a behavioral thing. You're not reading nutrition labels. You're not exercising. Like, what are we going to do? There's only so much insulin that you can have. So that's when it's like, hey, Tom, you are great at behavioral modification. You're really good at coaching. You're good at helping them figure out where they need to keep their pill box in their house to actually take it. Yes, it would be great to have that level. And then there's also community supports, right? We have community health workers at Sterling Healthcare, and they're a godsend. But you do need those kind of people to help navigate the system. It's hard. There's only so good you're going to feel if you don't have secure housing. So that's part of mental health integration as well, as kind of the social determinants of health, if you will.
Quick follow-up.
Thank you.
Renee?
Quick.
So we know that some states are doing this, right? Colorado is doing it. And if we're
Utah,
looking at
Tennessee.
legislative fixes, I'm hoping that maybe you would help us come up with ideas that would get us all the way there instead of, partway there if we're going to tackle this issue. So,
Sure, that aim high. But in the meantime, I'll take co-located or just hiring more psychiatrists.
Thank you.
Thank you. And I do have a bill draft. I'm happy to work with anyone on that. Senator Berg.
Thank you, Madam Chairman, and thank you very much for a wonderful, wonderful presentation. Are there, as far as you're aware, like when you all get together on this weekly Zoom with your primary care physicians, and is there a CPT code that you could bill for that? Or are you just spending hours of your time completely non-reimbursable?
Bit of both. So our community health workers are now, and thank you for whoever was involved in that, community health workers can now recover some. So when they do care coordination, so let's say, we talk about this patient and we come to find out like, oh, they are living in a travel camper. That's not good. Rebecca, community health worker, can you please call the family after this meeting and see about getting them a voucher or getting them on wait list, whatever it be. And she, I'm just thinking of one clinic, she can bill for those services. But right now we just kind of eat the cost of having provider schedules blocked because we just think it's that important.
And then a follow-up on your 90-minute meetings with a patient, are you able to bill at a higher level?
I do. I bill a level 5 for those.
Okay.
But,
All right. Thank you.
that's still
Thank you.
a sixth of what a primary care provider bills in that time.
Right. Okay. Thank you. Yeah, we do need to figure this out. And and I'm not sure, you're probably familiar with the Train New Trainers primary care fellowship that we're also working on. So
Yes.
we've got a few things going on simultaneously to try to tackle this issue. So I really appreciate what you're doing. Our last question is Senator Nemes.
Yes, I have a question and then a concern, a comment, if that's okay with the chair. How many mental health providers does an average patient see?
You mean how many patients does a provider see?
No, an average patient, how many mental health providers do they need to see? Because they don't always go to just one.
Right. Well, so ideally, if you see when you get started with a therapist, hopefully you click, you like this person, you develop a good therapeutic alliance, you want to stay with that therapist. So you would have one therapist, and then you may or may not need a psychiatric prescriber. So a psychiatrist or a nurse, a psychiatric nurse practitioner, somebody with specialized training. So you may see a therapist and a prescriber. But so we limit it to just 2 people.
Okay, and the other is a concern of your oopsie comment. Are you saying you don't have enough time to properly diagnose, so you're subscribing hardcore drugs that shouldn't be prescribed?
No, sir. So primary care. So if they are just using the screener, so we use what's called the patient health questionnaire. It's a validated screener for depression. It's referred to as like the PHQ. You may have heard of it. But we use it for every single visit. Even if you're there for like strep throat, you get a PHQ. And that is a pretty good screener for depressive symptoms. So a lot of our, we have trained our primary care providers to, if you see that it's elevated, you must address it. You need to ask the patient, hey, I noticed you said that you don't feel like being alive most days. Like, tell me more about that. Do you need to go to the hospital? Let's talk. If the provider doesn't have the time to, quickly ask, like, hey, do you know what a manic episode is? Have you ever had one? Has anybody in your family ever had one? And they, well-meaningly are just like, you seem so depressed. Here, I'll start some Prozac, which is not a hardcore drug. But I'll start an SSRI like Prozac, and hopefully that'll get you feeling better. You can, not always, but it is possible to actually precipitate mania, like send somebody who wasn't actually just a unipolar traditional depression, but who actually had bipolar depression. You can actually cause harm. You can actually cause them to be manic. I mean, you could catch it early, you could course correct. It's not a huge deal, but there's a reason why we take the time that we do to really figure out diagnostic clarity, if that makes sense.
It makes sense, but I still have a concern, even though it's not a hardcore drug. You said you could cause harm because you didn't take the proper time, because you're not getting paid for it, and you're asking us for help to get paid for it.
Well, for primary care is to be able to kind of, but also the expertise. They need to learn what questions to ask. And a lot of them, because they are worried about causing harm, they just hands up, like, yikes, you have mental health issues. I don't want to do that. You need to go find somebody to help you with that. Best of luck. And that's the last thing that patients who are depressed need to hear.
Right, and this is such an important conversation, and not everyone here is a healthcare professional, so we need further explanation. So it's really time that you need to be able to spend with your patients, and I said that was our last question, but Senator Meredith.
Thank you, Madam Chair. I appreciate you indulging me. And it goes back to this time factor. I'm looking at your slide about what to do about the unmet need. Incentivize more providers to pursue careers in mental health, education for primary care providers to tackle more mental health concerns, integrate mental health care into primary care. Can't argue with any of those, but that's kind of a long-term strategy. My career was in healthcare, but on the administrative side, so I'm always looking at productivity and efficiency. I was speaking to a primary care physician last session and asked her how much of your day is spent on the administration of health care, because you said we don't have enough time. And she said she spends about 2 hours a day. And I'm thinking, well, if you can cut that in half, then that's 4 more patients per day. That's 20 patients a week. That's 80 patients a month. That's almost 1,000 more patient visits a year.
Right.
And I know you well know that our administrative cost for healthcare is double what other industrialized nations is. So
Yes.
for you, how much of your day is spent on the administration of healthcare versus actually providing patient care?
Good question. My role is unique because I'm where I have, I purposely have administrative duties because I'm the director of behavioral health, but I'll kind of speak for my colleagues. I would say easily an hour and a half to 2 hours a day. Unfortunately, what most of them do is they just work through it, and then in the evenings is when they're catching up on all their charting and anything that has to be, corresponded during the business day. They prioritize that, and then bedtime after the kids go to sleep, that's for charting.
Well, I think that's one of the challenges of being in private practice is you're a full-time practitioner, but you're also a full-time business person.
Correct.
And something's got to give, and usually that's your quality of your personal life. And so we've got to address this. But I'm just surprised there's not more of an outcry about how much administration, how much bureaucracy is in healthcare.
I'm happy to lead outcry.
Well, we need to address that as well. But thank you. Appreciate
Thank you, Senator Meredith. And that is such a huge burden on healthcare providers. We hear about this a lot. We're working on prior authorization. We're working on some of that, but is also directly attributing or contributing to physician burnout, healthcare worker burnout. And just personally, my husband comes home and charts for about 3 hours a night. So after seeing 50 or 60 patients a day.
Living the dream.
So it's a lot. Yeah, it's a lot to ask. So thank you so much for being here. This was a great conversation. I look forward to working together and alleviating some of this stress and strain on our system. Thank you.
Thank you for having me.
Of course. And thank you, Dr. Cottle. All right. While we have a quorum here, we're going to go ahead and take up the administrative regs that we have on our agenda today. Did everyone get a link to all of the regs that we have here? Are there any questions? All right. I will take that as everyone had a chance to review those, and there are no questions, and I will consider these administrative regs considered and reviewed. All right. Next on the agenda, we have a dear friend of mine, Dr. Jeb Teichman, who has come here today to discuss sepsis in the community. And I have known Dr. Teichman since before he was Dr. Teichman, back in undergrad, and his wife is a dear, dear friend of mine too. Hi, Grace, if you're watching. And
I tried to get her here, but she wouldn't come.
Oh, she wouldn't come. Darn. All right, we're going to have to get her here. Okay, well, if you could just introduce yourself for the record and tell us why you're here, and the floor is yours.
Thank you, Madam Chairman. Good morning, everyone. I am a pediatrician and father, and I'm here today to share my story, and ask for legislation that if it were in place, my son would still be here today. I work with Families Fighting Flu, which is a 501(c) organization and this is our 20th anniversary, of families who have lost a loved one to complications of influenza, or had a family member who was severely affected. We have the stories of about 70 families on our website, familiesfightingflu.org. If you have a chance to look, I'm sure you will understand the profound effect that losing a loved one has on a family. All those family stories, those folks died of complications of influenza, which is basically sepsis. I also work with the Sepsis Alliance to bring education and promote legislation that will dampen this terrible condition. So I'm here today to put a face on sepsis and influenza, that of my son, Brent, who we lost to its complications. But before I do, please indulge me while I tell you a little bit about my son. Brent was a wonderful son, brother, uncle, and friend who had a passion for whatever he did in life. He loved music and was a self-taught musician and leader of his high school garage band. He loved watching sports, especially that blue school to the east, much to my dismay, being a Red School graduate. I didn't dare call him a day after they lost a game. He loved playing on league soccer teams with his twin brother. He also loved cooking for us as a family and friends when we would gather. And if Brent had a fault, it was that he learned how to cook for a caterer, and he didn't know how to scale down a recipe for 150 guests to our 6 people. And I had leftovers for a month. He always brought life to the party with his smile, his wit, and his humor. On November 2nd, 2019, just before midnight, my wife and I were 650 miles from home when we got the call that no parent or family member wants to receive. It was Brent's cousin Jake and his roommate calling us to tell us he couldn't awaken Brent. Brent first reached out to me 3 days before his passing to tell me that he had been ill for 3 days with a fever, cough, and sore throat. Classic influenza-like illness. It was too late to start antivirals, so I gave him advice on symptomatic treatment and told him to stay in touch. We texted the next day because that's what young people do. They don't talk on the phone. And I was glad to hear that his fever was trending down and he was feeling somewhat better. I next heard from him 2 days later when he called to tell me he was having trouble breathing. Brent didn't have health insurance, and not knowing how sick he was, I sent him to urgent care, figuring if he were really sick, they would triage him to appropriate treatment. That's the biggest regret of my life. Had I sent him to the emergency department, I am confident that he would be still here today. 4 hours later, I got that call. Jake called 911 and he was talked through performing CPR on his best friend and cousin. To this day, he is profoundly affected. I called Jake back a few minutes later and asked him if he'd hold up the phone so I could hear EMS working on my son, calling for round after round of epinephrine. And when I close my eyes at night, I still hear the beeping of those monitors. The official cause of death was multilobar pneumonia, etiology undetermined. But after 30-plus years as a pediatrician and 20-plus years as a CDC influenza sentinel, I know flu when I see it. Brent had no chronic health conditions that would have made him high risk for complications of influenza. He was a healthy 29-year-old. There's a hole in our hearts that will never heal. The loss of a child is devastating no matter what the age. The irony here is that throughout my years as a pediatrician, I've been a tireless advocate and early adopter of vaccinations. You'll forgive me, I'm just a little bit nervous. I've never done this before. I always made sure my family got their flu shots, sometimes bringing the nasal vaccine home and squirting everybody's noses. But when they're 29 years old and they think they're invincible, you can't no longer grab them by the hand and take them to get vaccinated. Brent had it on his to-do list, but he never got around to it. In his obit, we requested that in lieu of flowers or donations, we wanted people to go get their flu shots. And it went viral on the internet. We were uplifted, and to this day, we still receive pictures, postings of family, friends, and my former patients getting their flu vaccinations. And we feel that by telling Brent's story, we may have saved another family from falling his fate. I've joined with Families Fighting Flu and the Sepsis Alliance so that Brent's legacy will be increasing acceptance of vaccination and awareness, because as we all know, it's not just the flu. It can take the life of a healthy young man, and it did. It took my son. As I said, Brent wasn't vaccinated. Vaccinations are the best thing you can do to decrease your risk of falling victim to sepsis. These are Brent's vital signs. Those of you who are healthcare providers might recognize that they meet what are called systemic inflammatory response syndrome, or SIRS, criteria. These are criteria that healthcare providers use to recognize those who may be septic and to act appropriately. Hospitals and emergency rooms do this on a routine basis. Outpatient facilities like urgent care, where Brent was seen, are not required to do that. And if that had been recognized, he would still be here. So what is sepsis? Sepsis is the body's overwhelming, life-threatening response to infection, which can lead to damage, tissue damage, amputations, organ failure, and death. It can impact in people of all ages, including the very young, older adults, and those with weakened immune systems, and as I just stated, healthy individuals. It knows no racial or socioeconomic boundaries. The risk of sepsis can be greatly decreased by vaccination, as I've said. So, sepsis affects 49 million people worldwide each year, including 20 million children under the age of 5. As a resident, I can't remember every night I was on call, I admitted children of all ages for what we called then rule-out sepsis. Sepsis takes the life of 11 million people worldwide. More than 1.7 million people in the United States are diagnosed with sepsis each year, 1 every 20 seconds, and every 2 minutes, 1 person dies of sepsis in the U.S. An estimated 350,000 adults in the U.S. die from sepsis each year, more than those who die from stroke, prostate cancer, breast cancer, or opioid overdose combined. Each year, more than 75,000 children develop severe sepsis, and 6,800 of them die, more than succumb to pediatric cancer. Sepsis causes 261,000 maternal deaths every year worldwide. It disproportionately affects the black community. Blacks bear twice the burden of sepsis versus whites. Survivors have a shortened lifespan, and 1% of them undergo amputations. Missed infections are the 3rd most common cause of diagnostic errors in malpractice cases. Viral sepsis is the most common complication in severe COVID-19. 78% of COVID-19 hospitalizations in the ICU have sepsis. The cost is staggering, $62 billion a year. And sepsis is the #1 cause of hospital readmission, costing another $3.5 billion per year. In 2023, a survey of 5,254 hospitals showed that hospitals participating had sepsis committees, 59% of them, 66% dedicate time for sepsis leadership, and most are reporting achieving their goals. In February 2016, JAMA published the 3rd International Consensus Definition for Sepsis and Septic Shock, Sepsis 3, which is used by hospitals to recognize patients with sepsis. I spoke at the International Forum for Sepsis in the community in April, telling my story. This is a distinguished body of world-renowned researchers on sepsis, some of whom came up with the definitions for Sepsis 3. They are moving towards early recognition of sepsis in the community, as early detection is key to saving lives. As I said, urgent care facilities do not do what the hospitals and the emergency rooms do when screening for sepsis. So what I ask is a version of Lauchlin's Law that was passed in Maryland and signed by the governor in April. Lauchlin DeSantis was a 5-year-old boy who died in 2020 from sepsis precipitated by influenza. His parents lobbied the Maryland legislation to write a law that requires hospitals and urgent care centers to have sepsis training and protocols in place to recognize and treat patients with sepsis. That's all I have. I want to thank the Sepsis Alliance and Lachlan, Love for Lachlan, a nonprofit that was started by Lachlan's family, for help in this presentation. Thank you, Madam Chairman.
Thank you so much for being here. Thank you for sharing your story. It's devastating, and no one ever wants to hear of this happening. You're brave in coming and telling us the story and sharing this and encouraging vaccines. And I, for one, didn't realize that urgent cares weren't held to the same standards, and that this wasn't a requirement. So thank you for bringing this to our attention. This is very important. Can you tell us what the difference between sepsis 2 and sepsis 3 is? We passed a law last year requiring coverage for sepsis 2.
Thank you. That's a great question. I'm here today representing myself and my family. I haven't got authorization to speak on behalf of my employer. I can tell you sepsis 3 is just another definition of what sepsis is. It differs from sepsis 2. It's one step up. But that's all I'm authorized to say.
Okay, thank you. I understand. All right, we have some questions. Senator Elkins.
Thank you, Madam Chair, and thank you for your testimony this morning. I could add to that. I suffered sepsis in 2015. I went to an urgent care facility, and it was not diagnosed. I went to my primary care physician, and I explained to him that I had pain all over my body, including the back of my knees, and I had read that that's probably lymph nodes that were inflamed and hurting, and I believe that to be the case. Sent me home, not diagnosed. Went to an emergency room, not diagnosed, and by then I was really comatose, and so my wife took me to another emergency room, and finally, after several hours in the emergency room, they admitted me and finally diagnosed me with sepsis. In 6 days, nearly comatose. I remember laying in bed, feeling the sheets on me, and they burned so badly that I kept thinking, I wish somebody would move these sheets, but nobody did. Nobody knew that. I couldn't communicate that. So I think it is key that we learn and train better to diagnose, and finally one doctor deciding that he would admit me until they figured out what was wrong with me is the only reason I'm sitting here today. I don't think that you could have done anything differently with your son to have helped his diagnosis. I appreciate that, but it was so easy to overlook and think it's something else, and it happened so many times to me. So I appreciate your testimony. I sympathize with you, and I also agree that we need to find ways to diagnose this better and better train. So thank you. I don't have a question.
Thank you, Senator Elkins.
Thank you, Senator. Thanks for sharing.
Senator Carroll.
Thank you, Madam Chair, and thank you for being here today. Can you talk a little bit about, I'm sure through with a nurse practitioner or an RN, a doctor, whatever level, that there is some training to identify this throughout the educational process for each one of these levels. Where are we lacking there? I mean, if there is training within our universities before they become RNs, LPNs, whatever, is it just a specific protocol, that steps that you go through? Is the diagnosis still subjective? Is there really a foolproof system to put in place to identify this, or is it just getting across the message that you err on the side of caution every time there is any question about it?
Thanks for the question. I've given this presentation to the residents at Norton Children's Hospital, and when I flash up Brent's vital signs, they all immediately recognize that he met SIRS criteria. This is taught in school. It's just, and required of the emergency department and the facilities to screen patients within their doors. And using those criteria, using sepsis 2, using sepsis 3, and then have a protocol on how to treat. And the hospitals and facilities are doing that. The urgent cares aren't required to do that.
And someone else might know the answer to this. And from time to time, I've been to urgent cares or taken family, and can't say that I've always been real comfortable with the care that I received. And just to be frank, sometimes it seemed like that these were perhaps medical professionals that couldn't get a job anywhere else. I don't mean to sound harsh, but that's kind of the feeling that I got. And are we so in such a hurry to expand the number of providers throughout this state, and these urgent care places are everywhere, that quality is lacking? And you may not even want to comment on that, but that's just a personal observation.
I can comment as a pediatrician and primary care physician. I try to keep my patients out of urgent cares and emergency rooms because no one knew them better than I did. I wish they would call me before they would go, because most of the times I could tell them what to do to get through the night and see them first thing in the morning. That's me. I'm one of those compassionate physicians that the previous speaker spoke about. Not all of us are like that. These days, and this is just my opinion, these days, most people who graduate from medical school and residency are in employed situations. It's quite different when you're an entrepreneur physician. I see Senator Dr. Berg nodding her head. She understands. It's quite different. I think there's a variety of folks who work in urgent care. Some of them are great emergency room physicians. Some of them not so much. There was one time I sent my wife to urgent care because it was the day before Christmas and she needed some medication for her cough that worked. She wasn't prescribed the right medicine, and she was actually prescribed a cough syrup that conflicted with her SSRI and wasn't even asked. Yes, so I agree. I've never been satisfied with the quality of care, but it's important that we have that resource and that it works so that we keep people out of the emergency room who don't need to be there. They're adequate to handle the common issues, but they need to recognize the serious ones, like my son.
Thank you. Senator Douglas.
Thank you, Madam Chair. Not really a question, but more so just some comments. I agree with the compassionate physician deal. I'm one of those guys, and it really affects our heart. And most of our public does not understand that, how much it affects us. One of the I'm actually pushing to get more primary care and more private practice physicians back out into the healthcare space. The other thing that a lot of our public or those people outside the space don't understand is how corporate medicine really is affecting the quality of care that we're delivering here in the Commonwealth of Kentucky and in our country. I know sometimes people may say, well, that's political suicide for me to say that, and I don't mean it that way. I just simply know that those of us in the healthcare space will shake our head yes, because we know it. We've been there. We feel often what our patients feel, and they think we don't. One of the things that I want to say in this particular space is I don't know whether or not, I don't know the facts I don't know whether labs were done and labs simply weren't missed or labs weren't done, or if information was given, please call your primary care physician or please go to the hospital because we can't treat. I don't know those facts. And for that reason, I really, 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 really want to caution my colleagues in the General Assembly about making everything legislative. Our job is to stay out of the back pockets of our taxpayers. Our job is to stay away from controlling people who are elected locally to serve people locally. I think we really, in the legislation, in the General Assembly, I think we really have to be cautious where we put our feet in terms of what our Commonwealth Constitution is asking us to do. The healthcare space is one that very, very few people really understand unless you're in the healthcare space. And we both know, and we all know that, those of us who are physicians in this room. And I don't want the legislators in my healthcare space. And I'll say that. You've heard me say that. I don't. They didn't go to medical school. They haven't sat 3 feet, 4 feet away from Mrs. Jones while she's crying like a 5-year-old because she just lost her son to substance use disorder. They haven't been there. And they won't be there because they don't have the training. So I'm really sorry for your loss. I am. And I think that we should do whatever we can do, but I'm not sure that legislation is the way to do it with a bunch of people who don't understand the healthcare space like we do. Thank you, Madam Chair.
Thank you, Dr. Douglas. Senator Tishner.
Thank you. Thank you so much for sharing your story, and I'm so sorry about your loss. We've dealt with sepsis in our family many times with my father. Just looking over the stats, it's just shocking how many cases of sepsis exist. Do you have? There's many reasons that people can become septic. Do you know what the stats are of how many are caused by a viral infection from pneumonia or flu versus other?
When I was in school, we were taught sepsis was a bacterial illness. What we know now is it's an over-exuberant immune system that can be activated by a viral infection, by a fungal infection, or a bacterial infection. And the viral infections are much more common. I don't have the statistics on the breakdown of the cause. The end result is always the same, though.
Yeah, it is. I know my father's experiences with septic, I think he probably 5 or 6 times in the last year of his life. None of them were viral. They were all bacterial. So I was just curious to know those statistics of viral versus bacterial. But I'll do some of my own research. Thank you.
Senator Berg.
Thank you, Madam Chairwoman and sir.
I don't think your microphone.
I'm so sorry for your loss.
Thank you, Senator.
I know how hard that is. But I also just want to tell you, sir, that I so appreciate you coming here and sharing this story with my fellow legislators. Because the important take-home point for me is that sepsis, once you get septic, as healthcare providers, our ability to keep you alive is limited. We do not do a great job of treating sepsis. And that is why prevention is so important. And I cannot stress to my colleagues enough, the data is clear. Vaccinations save lives. There is no question about it. People that don't believe that need to go and look at the data. Thank you.
Thank you, Senator.
Okay. Well, those are the questions that we have. And I just, again, I want to just express our heartfelt sorrow for your loss.
Thank you, Representative Mosier, and thank you for the invitation to speak to this distinguished body.
You're very welcome. Yeah, anytime that we can take a look at standards of care and quality of care, whether or not it's prevention through vaccines or training, whether or not it's legislative, I think raising awareness is a good thing. And you are doing a very good thing. And this is, just I know it's as a parent, you probably feel like it's your job now to advocate, and I know I would feel the same. And I know that Brent is proud of the work that you're doing. So
thank you.
Thank you. Okay. Next on our agenda, we want to talk about human trafficking and what we are seeing in Kentucky, kind of an update on Kentucky actions and how we're working with other states. We have quite a few presenters here. I know that we have some friends from the Attorney General's office and anyone that we have here in the audience who is part of this presentation. If you could please make your way to the front table. And we have Teresa Flores, who is on with us remotely. So I'll give you all a minute to come up and get situated. And if you could just introduce yourselves for the record. And I think that you all have your presentation outlined, so you can decide who goes first. But I think, I think we're going to tee things up with Teresa, who is online. Okay. All right. We have Teresa all set to go.
Well, thank you so much for inviting me to be a part of this really esteemed panel of my colleagues and advocates in the fight against human trafficking. I live in Columbus, Ohio, and have been doing this work for 15 years, sharing my story all around the country, trying to open up people's eyes to what the words human trafficking mean and what they look like here in the United States. I am actually a survivor of human trafficking. I also am a licensed social worker and have a master's in guidance counseling. And I have made it my mission to do this. I have published 5 books on the issue. Several are bestsellers. And I also am the founder of the SOAP Project, Save Our Adolescents from Prostitution, which is a nationwide nonprofit that works with helping survivors heal and identifying missing children who potentially could be trafficked at hotels and motels during big sporting events. For me, I think that people are shocked by my story because I don't fit that mold of what people think a trafficking survivor looks like in the United States. I grew up, I would say, privileged in Ohio, Indiana, and Michigan. I had a mom and a dad that I was not abused, which is not the norm. I wasn't molested, I wasn't a runaway, and I didn't do drugs. So I don't fit into that typical mold of where our mind goes to. My dad was a big executive for General Electric, and I have 3 younger brothers. I come from a pretty big family. And nobody would have had any idea that I could potentially be vulnerable and be a victim of human trafficking one day. I'm sure that it never entered, any of my family, my relatives' mind. But every kid is vulnerable. Every person is vulnerable in some way. And these traffickers know how to get you. They know how to identify that vulnerability and then manipulate it. They're experts on that. What made me vulnerable, particularly besides just being a regular teenage kid, is that my dad got promoted and transferred every 2 years. So the whole family would be uprooted and move every 2 years. Like I said, all over Ohio, Indiana, Michigan. So I basically was always the new kid, always trying to fit in, always trying to catch up in school. And as fun as that was in the beginning, it got very difficult later. And I would say that I was pretty lonely, and really just wanting attention as well. Just, like most 15-year-old girls. We moved in the middle of my ninth grade to a different community outside of Detroit, Michigan, very upper class. And somebody saw my vulnerability and abused that. He groomed me for 6 months, went to my same school, was older than me, identified me, gave me compliments. It was a whole process, of course, that I didn't recognize. And then simply asked me if I wanted a ride home from school one day. It was that easy. Um, and I thought he was going to take me home, but he didn't. He took me to his house, made some excuse. So, I just need to grab something. And I believed him. I was very vulnerable. I went in, and that led to me getting raped because I was drugged. He gave me a soda, a pop, and it had drugs in it, and I got raped. As bad as that was, because that was pretty horrific, being a virgin. And I didn't tell my parents that afternoon. This was 1980. There's no such thing as date rape stuff back then, and education and rights. And so I kept my mouth shut, thinking it would just be okay. But it wasn't, because it led to 2 years of them blackmailing me over photos that had been taken that day. They knew where my dad worked. They knew his office address, boss's name, threatened to take these photos to them, threatened to put them all around school. No, we call this sextortion today. And it is the leading threat to teenagers today. And that's because we're not doing anything about it. So they sextorted me. I was made to earn these pictures back. So it was blackmail with sex. And they would call me out in the middle of my night of sleeping at home. I had my own private phone, and they would say, "Okay, you're coming tonight." And there was no, maybe or no about it. They threatened to kill my family, and they would follow my brothers home from school. They knew exactly where I was at all times. And I know that that surprises a lot of people, because I got to live at home and I got to go to school. But that was perfect for them, because they could always keep track of me. And that was another way to monitor me. Um, so I would have to sneak out at night, in the middle of the night, and they would pick me up and deliver me to very, very nice houses all around the Detroit area. I didn't walk the streets. I didn't do drugs. This was just with the way my story was. And so they would basically sell me to other men in their organization. And I had to do that many times a night, many nights a week, or almost 2 years. I thought that I was trying to earn back the pictures, but I didn't know at 15 and 16 years old that they were never intending to give me these pictures back. And I couldn't tell anybody because of the threats that they made. I was terrified and stuck, there were red flags. People could see this. And now, reflecting back, I've had teachers and people and students write me and say, "Oh my gosh, yeah, you're right. I saw something and I thought something was happening, but I didn't know what." And that's what we want to prevent anymore going forward. My grades dropped. I was sick all the time. I was depressed. And but everybody's like second guessed it, saying, "Oh, it's teenage hormones, or it's she's having a hard time adjusting to the school." Nobody, was educated back then on this. Um, and so it took a really, really bad night for my life to change, which is a lot of times the cases for survivors. I was kidnapped one night by some other members of this group, and taken to a motel in the inner city of Detroit, where I was sold to 21 men in one night. and left for dead. I know they were going to be coming back for me, and my life would have changed drastically because they wouldn't have taken me back home again. And that morning, I decided that my story was not going to end this way. And I put on my pajamas and walked out of the motel and into a little diner where I got rescued. It took probably a few more months before my family, we got transferred again, and they still had no idea. Nobody knew what happened to me. And then it took many, many years for me to be able to put the words human trafficking to my story because I never knew it was called that. And when that happened, I decided that I was going to commit my life to sharing my story with people, but also helping other survivors on this road because it's a long lifetime road of recovery, let me tell you. In 2010, I started the SOAP project, which stands for Save Our Adolescents from Prostitution. And we have given away over 3 million bars of soap with the National Human Trafficking Hotline number on it to hotels and motels all across the country. We're preparing now to go to our 14th Super Bowl. And we've done Louisville, Kentucky Derby several times. So we've been down there as well doing it. And we're just really passionate about having something that people can do to fight this. Because people, I can tell you, I speak many times a month nationwide. And, when I ask the audience, how many of you heard about this? How many of you know about human trafficking in the United States? It's still 90% that have never gone to a training, don't know anything about how it is here. And after 15 years, that's really sad. That makes me really tired. A few years ago, I worked with a senator in Michigan, and she had put together a proposal of 22 bills to fight trafficking, everything from expungement bills to raising the minimum entry fee to strip clubs so that those extra dollars could go into a fund for victims. And also a law that she got passed that was removing the statute of limitation for victims of trafficking. As far as I know, Michigan is the only one that still has this law. So when you're a minor, and you've been trafficked, it takes a long time to have the courage and the mental stability to prosecute. And we all want to prosecute the traffickers, but what we need a lot of time, a lot of healing for that to happen. So the law was 6 years. After 6 years of being out at age 17, I still didn't even identify with being a victim of trafficking. Even 10 years, 15 years later, it took until I was 40 to realize that I had been trafficked. And really to start my healing. So Senator Emmons passed a law that was removing the statute of limitations for minors that have been trafficked in their state, meaning somebody that's 18 now, she can go back and prosecute her traffickers. It doesn't matter how old she is, and when she's ready to do that. They actually named it the Teresa Flores Law, and I'm really, really proud of it because I figure it's my gift to, unfortunately, future victims. But we need to be creative and think about, different kind of legislation that helps support victims. And personally, too, I believe that we really need to work on the demand of this in our country. I know everybody wants to go after the traffickers, but we really need to go after the buyer, which we used to call the John. But we need to make stiffer penalties on if you're buying another person. And really work hard on that. I think that's the main way we're going to see a change in our country. So thank you so much for allowing me to share my voice and my story with you. I know our stories are hard to hear, but this is a reality. This is the second leading crime in the United States. And sextortion is rising, at epidemic rates. So it is time that we really take a strong hold against this. And I'm confident that a great state like Kentucky can do some really good work. So thank you.
Thank you, Teresa. I really appreciate your sharing your story. It is difficult to hear. It's difficult to understand that this is going on in the U.S. and in Kentucky. But I felt like it was important for everyone to hear you and to hear what we are working on here in Kentucky. This really helps set the stage. This is certainly an area of human trafficking that we don't think about, and I think it's certainly probably more prolific with social media and different ways that we connect now versus in the 80s. It's scary to think about all of this and what's happening to the victims. So thank you for being here, and I'm going to hand it over to the folks at the table now, and I just want to thank all of you for being here and for your work on this important issue. If you could just introduce yourselves for the record to begin. Thanks.
Thank you, Madam Chairwoman. I'm Marissa Castellanos, and I work with the Coterie. I'm the founder and director of the Coterie. And I also work at Love 146, which is an organization that works on specifically child trafficking, direct services, and prevention. They're based in Connecticut and do national and international work. I'm not here in that capacity today. I'm here representing the Coterie and as a member of the Kentucky Statewide Human Trafficking Task Force.
Greetings. I'm Dr. Glenn Hardin. I'm a professor at Asbury University, and I am also the chair of the data working group at the Kentucky Human Trafficking Task Force. And Marissa and I have a presentation about that report that we put out.
Good morning. Thank you all for having me. Riwa Zakaria. I am the criminal chief at the Office of the Attorney General.
And we don't have enough seats at the table, but I know there's another presenter that will shift seats in a few minutes.
Right, and I'm not sure where you want her to speak, so I'll hand it over when you're ready. Thanks.
Perfect. Thank you so much. So we are going to start by talking a little bit about the statewide data report and the recommendations made in the report. There's a lot of data in the report. We're not going to go over all the data today, but you have it available to you, and we welcome questions later. And we will also talk a little bit towards the end about regional and national efforts that Kentucky's involved with in regards to anti-trafficking.
So yeah, I'm going to walk through the 2024 Kentucky statewide trafficking data report that we put out that the data working group put out in February, and I'll try to go through this as quickly as we can. Of the report, Marissa and I are the primary authors on that. I do want to start by just saying that human trafficking is a public health issue, and we're delighted that this committee is taking it seriously as such. The report has a lot of data. We can't possibly get through it all. I want to focus primarily on the report's recommendations that come out of the data that we gathered. Our first recommendation was to increase the institutional capacity to support anti-trafficking efforts. As you probably are aware, anti-trafficking efforts are cross-sectoral and involve civil society, government, religious society, businesses, but to coordinate those efforts, it is very helpful to have employees, merit employees in the government that are helping us coordinate those efforts. A second recommendation, which is especially pertinent to public health, has to do with increasing community resilience through policy change. We want to think about the ways that we can help our communities and individuals reduce their vulnerability to trafficking, and also help them to escape themselves if they get caught up in it. Obviously, prevention is the most cost-effective anti-trafficking strategy. We do recommend that we increase data collection and transparency and reporting. We collected the data that we could. It is still insufficient, really, to do a thorough self-evaluation of our anti-trafficking efforts. So the more data that we can collect in all of the realms of anti-trafficking, which includes civil society, but also what the government is doing, is very helpful. We do want to focus on proactive law enforcement. That's not public health, so we'll just pass on that one. The prioritize survivor-centered, trauma-informed, culturally responsive human trafficking trafficking training. So we encourage you all to continue to ensure and increase the access to high quality training for the relevant actors. We do believe that it's important to increase and improve efforts to address labor trafficking in the state. Immigrants, such as our H-2A visa holders, are especially vulnerable to labor trafficking, but labor trafficking can also occur in familial settings, so it can also affect our citizens. We do encourage the improvement of standards of care for our service providers, and I think we have some other people addressing that, so I'm not going to speak on that. Support data-driven outreach and awareness efforts. Sometimes the data reveals things that can run counter to our intuition, so it's important that we course correct when we collect and review and analyze the data, so that we are doing the best that we can against trafficking. The statistics show familial trafficking is actually is one of our most common categories. So often people think of human trafficking as stranger danger, which exists, but the importance of recognizing that human trafficking can occur in the family is to raise awareness and to address those appropriate intervention issues is critical. And another our final recommendation is language access is really important to identifying and helping victims and survivors of human trafficking. It's not all people that speak English, and so making sure that we have the appropriate language is critical. I'm going to turn it over to Marissa at this point.
Thank you, Dr. Harden. And if you will bear with me, I will go through some of the national and regional work, which is connected, and you'll see some intersections with the recommendations. And then, of course, we welcome any questions you might have. So, Kentucky has been involved in a lot of regional and national anti-trafficking work. And the Trafficking Victims Protection Act was passed federally in 2000. Kentucky passed our first anti-trafficking law in 2008. And then we have an omnibus bill that we passed in 2013. And we've continued to do work, right, at the state level to improve our local policies. All since the first anti-trafficking work in Kentucky really officially began in 2007, 2008, we have been involved in work with other states and with national stakeholders to address human trafficking. And that's been through a mixture of collaborative meetings, various capacity building efforts, and some national project participation. I can say that folks here in Kentucky have been very actively involved in the ACF HHS Region 4 Human Trafficking Advisory Group, which began in 2016. And is one of the several different regions nationally of HHS. The regional office in Georgia has been a primary facilitator of that group, and historically, Catholic Charities of Louisville and the Kentucky Office for the Attorney General have been participants in that regional working group, and we have take on several projects across the different states that we've been working in, and some of that work has been utilized at the national level to push forward anti-trafficking work. Moving forward, the HHS Region 4 group has now begun to focus not so much on collaboration between government and nonprofits, but to focus on anti-trafficking in government groups. So moving forward, DCBS will be the primary representative from Kentucky involved in that group moving forward, and has been already involved in that. Oh, sorry, let me go back. There's also the National Human Trafficking Compendium, which began in 2017. It's convened by folks in Colorado, but is meant for government representatives from as many states as possible. I believe there's at least 27 member states involved in that compendium. They have quarterly meetings, and historically, Catholic Charities of Louisville has participated in those. I worked at Catholic Charities for 15 years in their anti-trafficking program and participated when I was there. And Amy Nestaganda, who will speak in a few minutes, also now represents Kentucky at the National Human Trafficking Compendium, discussing statewide efforts across the country to address trafficking. There's also a Child Welfare Collaborative, which is limited only to child welfare organizations. They have 25 plus member organizations and have bi-monthly meetings. And Kentucky is currently represented in that collaborative by DCBS, specifically Danielle Corey from the Child Protection Branch and the Out-of-Home Care Branch. She works also with Sydney Lawson to represent us in those efforts. We spoke earlier about standards of care as one of our recommendations, and some of the work that's been done really since 2017 here in Kentucky and in collaboration with folks in Florida and the Region 4 Working Group is to develop standards of care, guiding principles for service providers who are serving survivors of human trafficking. And so I was one of the co-authors, along with my colleague Amy Nestaganda, Bethany Giello from Florida, and Gretchen Hunt, who at that time worked at the Office of the Attorney General here. And we worked together to co-author the guiding principles. And it's 15 principles to improve standards of care for service providers. And since that guide was developed in 2017, 2018, we've done training in many different states, particularly most recently this year, which is why they're in red. We, in May, went to Tennessee and did guiding principles training with nonprofits in the Memphis area, but also in Nashville and other parts of Tennessee on standards of care, and even did a train the trainer so that now they have sustainability and are able to continue to offer that training in Tennessee. And we've had an ongoing relationship with the state of Texas, particularly DCF, their child welfare organization in Texas, DCPS. They have invited us many times to Texas to provide training to child welfare in that state. Of course, a very big state with a huge child welfare department. And we have trained them multiple times on the guiding principles, and already went earlier this year, and we will be going back in December to do a train the trainers with them. And so what we're seeing is that there is a need and a desire to have standards of care and to improve the way that we're providing services to survivors of sex or labor trafficking. And the guidance is a really helpful tool for folks, right? Because we don't want to start from zero and want to do good work, and we don't want to do harm. And that's what a tool like the guiding principles provides. In regards to sort of more national level participation, currently, there is a national effort through the Office for Victims of Crime and the Office on Trafficking in Persons. They are collaborating to develop national standards of care. And so in their recent literature review, they cite often the guiding principles that we worked on here as just one tool that they're utilizing in developing the national standards of care. That is a group, a technical working group of 21 or 25 individuals from across the country, and I'm honored to be a member of that group helping to develop standards of care for the larger anti-trafficking field that will be utilized by federal funded organizations across the country. Also, HHS has their Voices of Freedom project, which is a collaboration with StoryCorps, where they recorded stories from survivors of trafficking and folks in anti-trafficking work. And I know that when I was at Catholic Charities, we worked with members of the Bikita Advisory Board, survivors of sex or labor trafficking, to tell stories as part of the Voices of Freedom project, which is available for folks to access now. And then we also did work at the national level on the National Advisory Committee on the sex trafficking of children and youth, which was part of the Family First Act. And in Kentucky, I was a member of that group developing the recommendations, 101, I believe, or 108 maybe recommendations to states, and we worked with DCBS here to then look at and survey Kentucky and see how we were doing on those recommendations, and then report back to the committee. So DCBS, Danielle Corey specifically, worked really hard to do that assessment for Kentucky and report back to the National Advisory Committee so that we could continue to move forward how we're addressing anti-trafficking at the national and state levels. When I was at Catholic Charities and now moving forward, we have worked a lot across states on the National Labor Trafficking Conference, which is connected to one of the recommendations from the report. We see that there's labor trafficking in Kentucky communities. We know that it's happening. Amy will talk to you more about some of the services they're providing to that specific population, but we don't talk about it much. There's not much training on it, and we certainly don't know how to identify. We're not screening for labor trafficking, and if we're not screening for it, how will we identify victims and get them access to services, right? And so there need to be training efforts. We need to build capacity, and we saw that gap years ago, and in 2018, Catholic Charities kind of took the helm and said, we're going to provide a national labor trafficking conference, the first of its kind in the country. And it was hosted in Louisville. And since then, we had another conference in 2021, a virtual conference. And now we're getting ready for the next conference, which will be in October. And it looks like it'll be well participated in by folks from across the country doing anti-trafficking work. And we think that is a very important need to address, the gap in information and capacity to address labor trafficking. And so we're committed to continuing to do that work together. Recently, Catholic Charities and the Well of Lexington worked together to host Love 146 in March to come to Kentucky, to Lexington, and provide training on the Not a Number prevention education curriculum. which is a unique curriculum because it's working on becoming evidence-based. It's for children and youth, and it addresses both labor and sex trafficking. A lot of curricula out there only address sex trafficking, and so the Not a Number curriculum is unique in that way. And so we have a group of maybe 12 or 13 trained facilitators now in the state as of March who can go out and do prevention education using the Not a Number curriculum with youth across the state of Kentucky. And then one final thing I just wanted to make sure and talk with you about this morning is, I think, a really substantial project that's about to conclude. DCBS here received funding from the Office for Victims of Crime to do a 4-year project called the Improving Outcomes for Child and Youth Victims of Human Trafficking Project. So it began 4 years ago, and in that time, DCBS has been working hard on improving systems of care and identification specific to child trafficking in this state. And they've had a very coordinated approach. They've worked closely with the the Kentucky Statewide Human Trafficking Task Force and developed a resource guide, done a lot of work on training. So I've contracted with them to do training. They've developed a training on basic human trafficking overview, identification and screening of trafficking, labor trafficking, and sex trafficking, and are about to put out a training on familial trafficking, which goes to one of the other recommendations we mentioned. As of June, DCBS had trained more than 10,000 providers and child welfare workers in this state on trafficking, and so that number will continue to increase. And they're working on developing a screening tool. This screening tool is an important gap filler in the field. The youngest screening that is evidence-based in the nation on trafficking only screens down to age 13 for labor trafficking and down to age 10 for sex trafficking. So what about kids younger than that? We don't have an evidence-based tool to identify trafficking among those populations. And so DCBS has been working with researchers from across the country to develop a screening tool. And it's now going through the validation process and being tested. And this will allow for screening for both labor and sex trafficking for children and youth under age 12, which will hopefully fill a significant gap in the field. So a huge thanks to DCBS for their work on this particular project. And it's about to wrap up in September. And so connected to the recommendations that are made in the report, then what will happen once they no longer have this federal funding to support some of this amazing work they've done over 4 years? We need to find ways to sustain some of this work through the state and not be dependent only on these limited federally funded projects. So with that, I will pass it over to Rila.
Thanks, Marissa.
Sure. Do you need to use this?
Nope. Chair Moser, Senator Meredith, and committee members, thank you all for having the Attorney General's office here so I can tell you all a little bit about what Attorney General Russell Coleman has been doing during this administration. Our office can assist in 3 separate ways when it comes to human trafficking prevention. We have a unit dedicated to it's a special prosecutions unit. If any prosecutor in the state needs any assistance with any of these cases, our prosecutors can assist or even take over those cases for them. We have our Office of Victim Advocacy. If a person has experienced human trafficking or believes they are a vulnerable victim of trafficking, they can contact our office and we can get them resources and referrals through our advocates. And lastly, our Department of Criminal Investigations, DCI. We have trained officers who have evidence-based approach training on these cases who would also be happy to assist any law enforcement agency or any prosecutor in the state who might need their help. Our four biggest training groups, I'm going to try to summarize as quickly as I can, but our first is through law enforcement. We presented to the KSP post in Hazard on combating human trafficking through an evidence-based investigation, and this training was provided by 2 prosecutors in our office. Almost all our human trafficking trainings are being provided by prosecutors or law enforcement agents, so people who are having hands-on experiences with these cases. We presented to approximately 100 law enforcement professionals in Louisville on child trafficking investigations. And we also presented to Boone County school resource officers for the signs of human trafficking within our schools. Our second is our prosecutor trainings. We continue to present to prosecutors through PAC, our Prosecutor Advisory Council. We currently have 2 virtual videos where prosecutors, or any attorney really, can get CLE by viewing them. One is on human trafficking laws and prosecutions, and the other, we partnered with Safe Passage on supporting prosecutors on trafficking at-risk youth. Along the lines of supporting our prosecutors, we have also presented to Paralegals Association Conference as well on human trafficking laws and prosecutions, so they as well can look at those and identify signs of those cases. For our community partners, our third training that we do, we presented to CASA of River Region on the signs of human trafficking. This was a live and recorded session as well. And lastly, for our public awareness that we have in our office, we presented on human trafficking awareness just a few months ago in Paducah to Pennyrile Allied Community Services and Community Collaboration for Children. We're also scheduled to give a human trafficking awareness presentation this coming September at the Kids Are Worth It conference in Lexington. We've also presented to the Capital City Retired Teachers Association, and last year, I believe some of you all might have taken part in this as well, we presented to the Legislative Research Commission, this was virtual and live, on human trafficking laws and prosecutions. So I've just gone through some of the human trafficking trainings we have done, but we also give trauma-informed trainings, which are really important in these kind of cases, because you have to be able to talk to these vulnerable victims in a trauma-informed way with the correct questions. And we have prosecutors in our office who are trained on trauma-informed interviewing. And they have presented to law enforcement, prosecutors, and multidisciplinary teams on the advantages of asking questions in a specific type of way to these victims. Even today, one of our prosecutors is at the U.S. Attorney's Office in the Eastern District presenting on trauma-informed interviewing to them. And as we all know, a lot of these human trafficking cases do go federal. So we are partnering and working with a lot of our federal partners as well. Our detectives have also given multiple trainings to law enforcement that cover electronic crimes and cyber crimes as well. We have the resources in our office to investigate and prosecute these crimes, but we need to be asked in to collaborate with our prosecutors and our investigators. We have a large swath of criminal behavior that has been moved online or has been committed with the help of electronic crimes. This includes human trafficking and the solicitation of these victims. And that's why our office is here to assist and give any assistance to local law enforcement offices and sheriff's offices by providing them two different services through our Attorney General's office, and both are labs. Our first one is we have an electronic crimes lab that can examine cell phones or any other electronic means as well. So if there's any law enforcement agency or prosecutor who does not have access to a lab and they have electronics that need to be tested, they're welcome to use the AG's office for that. Our second lab is yellow. It has a great demeanor and a budding Instagram presence. Earlier this year, we swore in a four-legged detective in our Department of Criminal Investigations, DCI. K9 Charity is an electronic storage detection dog. She can sniff out micro USB cards along with any other electronic crimes that may contain CSAM, so child sex abuse material, or any other illicit crimes. K9 Charity has worked with law enforcement across the state. She has assisted in executing search warrants where it might take our detectives hours or a day to locate certain items, small as USB items. Our K9 Detective Charity can do that in a matter of minutes. We're very excited to have her, and if any representative or committee member would like to have a little one-on-one time with K9 Charity, we'd love to have that as well. Our office, we can do that. Our office is always ready and willing to assist anyone when it comes to victim services, public awareness, prosecution, or law enforcement. These crimes affect not only these vulnerable victims, their families, their friends, and ultimately our community members. So we are here for anything that, any law enforcement or prosecutor needs in our community. Thank you all.
And now I'm going to switch chairs and have our next speaker come up.
Oh, you are? Okay.
It's musical chairs today. Thank you so much. Is it on? Oh, it's not on. Sorry. And I made a cute joke about musical chairs and nobody heard it. My name's Amy Nastagonda, and I'm the director of the Bakita Empowerment Initiative at Catholic Charities of Louisville. Thank you. That's not the one did I send the wrong one? No, okay. So at Catholic Charities at Bakita, We are the anti-trafficking program, and we're based out of Louisville with Catholic Charities, but we're actually statewide. So we serve survivors of labor and sex trafficking throughout the entire state and have offices in Louisville, Lexington, and Owensboro. As you can see right there, I'm not going to read all of this for you, but these are some of the outcomes that we have had since we were established in 2008. The main two facets of our program is to provide those direct, intensive case management services to survivors of both labor and sex trafficking, male and female, foreign-born or domestic, of all ages. The other facet is we do prevention education for youth throughout the entire state. So we want to be able to help youth to understand what trafficking is, but we don't just focus on trafficking, right? We're talking about the things that may make youth vulnerable to trafficking. So talking about healthy relationships, healthy boundaries, understanding what a trafficker may or may not look like, right? Because they may have a certain idea of it. But then also, how to be able to recognize tactics, what are the services in your area, and who you can reach out to. So in this, I'm going to actually, based on what everybody was doing, I am moving my presentation a little bit, and I want to talk, about the different types of levels of prevention that are needed in services, but also the services that we do. So we're looking at 3 levels. We have the primary, so that's that maybe, that prevention education that we're doing for youth, the curriculum that we're using, but also it looks like going out into the community and raising that awareness of what trafficking is, right? This is trafficking, it's happening. How can the community support other programs, that are doing work that can raise protective factors for survivors? And then also training professionals. So what would it look like? We just actually got done doing a large training for 7 counties that's based in Louisville for their school-based therapists on what trafficking looks like, but then also what their reporting efforts would be and what their next steps were to be. Because I give an example, I used to actually work for 7 counties. And many moons ago, I started doing volunteer work in the anti-trafficking community before I started at Catholic Charities about 10 years ago. And it floored me when I learned about what trafficking was, about the amount of youth that I probably worked with that had been trafficked, but I didn't understand what it was. So we want to be able to have, our professionals that may come in contact with somebody that could be trafficked or have been trafficked to understand what that may look like and what their next step should be. So we want to do that. But then our next step, if trafficking has already occurred, then, we have the secondary and the tertiary. We're going to be looking at if trafficking is happening right then, what are the steps? What are the emergency things that we can put in place to help them leave that situation? And then we're looking at, which is kind of more of what we do, is that last one, is those long-term interventions afterwards. What are we going to help, the type of stability that we can put in place so that hopefully trafficking does not happen again? We want to increase those protective factors. So we do case management. What we're doing is looking at all the different types of systems and resources that a survivor might need and help them navigate that. Because it's really hard. If you are somebody that has exited a trafficking situation or still currently in a trafficking situation and you are needing stability, you're needing housing stability and you're needing job stability, you may need mental health resources, those are all very hard to navigate on your own if you don't know the systems. So we come in and we assist with that, okay, and help them navigate and connect that. And so our services are very intensive in the beginning. And then we're hoping that we're connecting them to these different types, right? So we're looking at, all of this that's on here and more. Marissa and I used to joke that we would write these grants and we would think of everything that we have been doing for participants and the needs that they had, and we try to put it all in these grants, and then we would get a grant, and then of course then we'd have 3 people come in that next month and they would need something we never thought about. And you're like, of course. So you're looking at trying to collaborate with different service providers too so that you can connect them. But these are typically the main types when a person comes in. Is that immediate assistance? What does that look like? Is that they're needing, to be placed in a safe shelter? Are they needing an emergency hotel room? Are they needing housing? Do they just need a food card? And then, going on to more long-term. What does that look like? They might need legal assistance. They need that education. It's not on here, but really housing is a huge issue. That is something that we are seeing daily. daily. Our referrals have actually increased substantially over the last year. And the main thing that people are looking for is housing. So we are working on that. And so you're kind of looking at these different types. But there are a lot of barriers to services. One I want to point out is people are only serving certain populations. When I identified the work that we do, I will let you know, based on my knowledge, we are the only agency in the state of Kentucky that works with both labor and sex trafficking. I believe we're the only one that provides case management to labor trafficking at all. We're one of the only ones that works with both male and female. So, we have a lot of services that may be focusing specifically on female sex trafficking. And so that is hard because then there's lots of populations that are not able to reach services. There's not services for them, or there's that lack of knowledge of understanding that, of the labor trafficking, like Marissa was saying in her report, or also that maybe a man has been trafficked and may need resources. I'm going to repeat what the first presenter said. There's a lack of capacity. There's not enough service providers to be able to provide these services. We're statewide, and we are a mighty, mighty team of 5. So we try our very best, but we have to put people on wait lists. Our prevention education goes on wait lists because we just cannot meet the need, unfortunately, and we wouldn't be able to give good practice if we were to take in everybody, unfortunately. But a lot of people are that. What we noticed is right before pandemic, it felt like there was a lot of collaboration happening in the anti-trafficking world, right, in Kentucky, because we were recognizing what it was and recognizing how we can all work together. And then pandemic happened, right? And staff became scarce, resources became scarce, and so it was a lot of working again in silos. And we're now just starting to come out of that, but it is really hard. We work when we get somebody that's referred to us, and we know that they may need mental health treatment or they need an emergency shelter. It may take us a week to find a resource, because people are just at capacity, and so that's been really hard. A lack of understanding of what trafficking is, so kind of like giving you back to that example when I worked at 7 counties, so people not recognizing it. So they may have somebody that's been trafficked, but they don't recognize of what trafficking is, so they're not able to give them, refer them to the best possible service provider. And then also some concern with our services is the trafficking, when you're doing trafficking specific services, it's actually not regulated. So in Kentucky, none of the services are regulated. So if I was a person that had never done trafficking before, any anti-trafficking work, and I decided I wanted to start a house for trafficking survivors with no training or any knowledge of it, that could happen. And so there's been issue of people not being able to follow best practice, and people are going into it with a very open heart and wanting to serve, but not understanding that the trauma that can come with those that have been trafficked and the trauma responses, and so not knowing how to work within that. And I just do want to point out too, we have such a gap with labor trafficking survivors in the services, and there are a lot of needs there. We work a lot, in the legal realm of trying to connect people to immigration legal services, because they are able to actually, if they've been trafficked, then they can apply for what is called a trafficking visa. And that's amazing, because once you get the trafficking visa, they can get their work permit, and then they can have their social security card, but until then they cannot work, they cannot obtain resources, they cannot obtain getting housing, and so we help provide all of that. And sometimes that can be upwards of 5 years that we're providing for an individual or family for that. So these are just some of the barriers. It's just there's so much need, and we just don't have enough to meet it. But services are really important, and different types, all different types of services are important. If somebody has services in place, it increases your protective factors. So if a person has housing, that increases a protective factor, right? They don't have as many of the vulnerabilities as if they happen to be living on the streets and all the vulnerabilities that come with that. Or they are able to get access to mental health services, and that decreases. They have more of a community. They're able to live in a place where they can meet people and feel like they could reach out. The more we increase these protective factors, the more we will decrease the risk of someone being trafficked or being trafficked again. Because unfortunately, what we can see is even if service providers step in place, if we're not able to access the stability and, an adequate time, and sometimes it's really hard, sometimes we're looking for adequate housing for months. And what are we supposed to do in that meantime, right? Because the shelters are full, and then there's no other resources. And then sometimes then the trafficker will reinstate themselves in that person's life, because at the end of the day, the trafficker may be exploiting them, but maybe they're giving them a consistent place to stay and giving them food to eat, or a little stipend to be able to provide for their family. And they have to look at that. And then the more we do that, the more we increase the empowerment, because that's what it's in our program name, right? And be a key to empowerment. Empowerment can do so much for people, and it increases that empowerment and increases that stability. So thank you.
All right. Thank you so much. This is so much information, and we're going to have to wrap up in a few minutes, but I really appreciate everything that you all are doing, all of these great partnerships. And when you're talking about some of the barriers, especially to the lack of capacity for treatment providers and referrals, you talked a little bit about training and how you train new trainers, especially in Tennessee. You talked about a program that you've worked on. Is there a training module that you've worked on? A few years ago, we passed a law to implement mental health first aid, for example, as a training module for understanding mental health needs and how to de-escalate and how to refer someone. Is there something basic that we could do to help get this information out where it's needed?
Thank you for that question, Madam Chair. So yes, there are some resources that are currently available, but there's a need to continue to build out those resources. And DCBS has been using a human trafficking 101 training that's online and recorded for their child welfare staff and partners, which provides a basic overview of trafficking and service needs and how to access services. And then more in-depth trainings have been developed on sex trafficking and labor trafficking. Each of them is about a 1.5 hour commitment. Right. And so then the question is, the time and who can attend those, and then making sure you're addressing issues like turnover and making sure there's a process for continually providing training. And I think that is an issue across disciplines in making sure we're saturating the professions that engage with survivors of trafficking, knowingly or unknowingly, and making sure that they're informed. I remember very clearly doing a training with the NASW, the National Association of Social Workers. I went to their office in Frankfurt years ago and did a training. 2 weeks later, I got a call from one of the attendees from an emergency department. She was a social worker there, and she only knew to call us because she'd gone to the training 2 weeks prior. And I say that to just highlight how important the training is. We don't know when it could happen that someone comes in front of them and they need the access to services and that information. So there is a need to have specific avenues for providing training consistently. And then the training we were providing in Tennessee and Texas was guiding principles on standards of care and making sure that there's sustainability and having people who are trained to do that. We don't have a system for doing that here, right? We provide it here when we're requested to do it. So yes, there is material available, there is content there, there's a process, but there's no system in place to move those things forward in a consistent way.
Yeah. Okay. Well, if you think of a way that we can help with that, let us know for sure. I want to give Selena McCormick a couple of minutes. She's online, and she's a forensic nurse violence prevention coordinator at St. Elizabeth Healthcare. And I know that there are some great things happening in the healthcare space as well. So I wanted to try to tie all of this together with some of the things that are happening when a victim does seek help at a hospital or in an emergency room. Selena, are you on?
I am, yes.
Thank you so much for being here with us.
Good morning. Thank you so much for having me. My name is Selena McCormick. I am a forensic nurse, a nationally board certified adult, adolescent, and pediatric sexual assault nurse examiner, and the violence prevention coordinator for St. Elizabeth Healthcare in Northern Kentucky. I also chair the Northern Kentucky Violence Prevention Task Force, a coordinated community response to violence in which we strive to heal our community and prevent violence through collaboration. The St. Elizabeth Forensic Nursing Team provides comprehensive medical care to victims of sexual assault, intimate partner violence, family violence, child abuse, elder abuse, and human trafficking. For those who are unfamiliar with the forensic nursing model in the response to human trafficking, we acknowledge that all these crimes bleed together and we individualize care for trafficking victims. Our encounters may include screening, a conversation, safety planning, a sexual assault examination, a physical assault examination, evidence collection, and resources and referrals. We respond 24/7 to consults from all of our emergency departments and inpatient units at our 6 locations, 5 of which are in Northern Kentucky and 1 in Southeast Indiana. We know that victims of human trafficking are often hidden in plain sight and frequently turn to healthcare services for medical attention, whether due to injury, infection, pregnancy, or mental health and substance use needs. Unfortunately, without proper training, many healthcare professionals may not recognize the signs of trafficking or how to respond or know how to respond appropriately, leaving victims vulnerable and unsupported. Prior to joining St. Elizabeth, I was the coordinator for a forensic program at a large trauma center in Central Texas. Texas has taken a proactive approach to combat human trafficking by implementing laws and regulations that mandate education and training for various professionals, including healthcare providers. Senate Bill 1199 was signed into law in 2019 while I was still practicing in Texas, which required that licensed medical professionals, including physicians, nurses, and social workers, amongst others, receive training on identifying and responding to human trafficking as a condition of their licensure. The training is designed to help healthcare providers recognize human trafficking or indicators of trafficking and red flags, signs and symptoms that may suggest a person is being trafficked, learn protocols for safely reporting suspected trafficking cases and connecting victims with appropriate services, and learning trauma-informed care with an approach to providing care that acknowledges the complex trauma experienced by trafficking victims. So when this law was passed, my colleague, Dr. Pamela Green, and I developed a training which we submitted for approval to the Texas Health and Human Services Commission. In addition to the curriculum requirements set forth, our training included our system-wide protocols and algorithms, which we developed for a uniform response to trafficking across our organization. Our trafficking was approved and added to the approved list of education materials for Health and Human Services. These changes have led to an increased identification rates and more effective interventions. The success of the program really demonstrates that targeted education can make a tangible difference in the fight against human trafficking. I really do propose that in Kentucky, we introduce a bill requiring that all licensed healthcare professionals complete mandatory training on human trafficking as part of their educational requirements. This would really ensure that healthcare professionals are not only aware of human trafficking, but are empowered to act effectively. A proactive approach will help in identifying and assisting victims, ultimately reducing the prevalence and impact of trafficking in our community. We know that anyone can be a victim. We know that trafficking is covert. Traffickers are really good at hiding and disguising their victims and their acts. Some individuals don't realize they're victims or don't know how to ask for help. So it's important that we know how to screen, recognize, and respond. At this time, there is no data that supports universal screening for trafficking. So we screen patients who exhibit those red flags. But in order to screen the appropriate patients, we need to understand what trafficking is and what trafficking is not. And choice of language is paramount in these interactions. In a Polaris Project survey, 69% of victims disclosed that they had access to health services during their exploitation. 85% of those victims received treatment for an illness or an injury directly related to their exploitation, and 57% of those victims reported never being asked about trafficking or abuse questions during any healthcare visit. So trafficking, we have to recognize it as a public health issue, and our healthcare providers have to be on the front line of this fight. Our job is to recognize the red flags and offer help to victims. And again, in order to do this, we need to know how to recognize those red flags, how to screen the appropriate patients, and how to respond to disclosures, making sure that the patient's health needs are addressed in a holistic manner and that the patient gets connected with appropriate resources in the community. So I truly urge you to consider supporting the introduction of a bill to mandate human trafficking education for licensed healthcare professionals. I think your leadership in this matter can make a significant difference in the lives of countless individuals and strengthen our fight against this egregious crime. So I thank you all so much for your time, for allowing me the privilege to be here today, to be a voice for the voiceless, and to honor the many, many patients from over the years who have had the bravery to disclose their stories to me.
Okay, well, thank you so much, Selena. Thank you all for being here today. This was really good information, great food for thought. I think this whole day has given us a lot to think about today. So we do have a couple of questions. I don't know if our members can keep them really short. I know that we are at time. Senator Tishner?
Thank you so much, and thank you all so much for the work that you're doing. I think this is just a disgusting issue that we have to deal with that has a long, long history. And the more I've learned about it, you mentioned that the pandemic, hurt your all's efforts. It woke me up. I had some time to do a little bit of research and become aware of what was going on across the nation and Kentucky as well. And it's absolutely shocking and staggering. My question would be, and I wanted to say thank you to Ms. Flores for sharing her testimony. I was able to read one of her books just last month, The Slave Across the Street, and I would encourage anyone to read that book. It just opened my eyes to the issue that could be right next door and we don't even know. And with phones available the way they are now, it could just be so much more pervasive than it was when she was a victim. My question is, we have so many avenues of trafficking, familial, which is very pervasive. We have what's coming across our border, just testimony in Congress last year with 85,000 unaccompanied minors that we don't know where they are now, likely could be victims of human trafficking and sex trafficking and labor trafficking. Of course, the sextortion and exploitation online, where we have Facebook and Meta that don't monitor those things. So child pornography is pervasive. Those are all victims and continually being sold to buyers. So that comes to my question. What are the challenges to going after the buyers? We've seen traffickers on national news, Epstein and Maxwell, get locked up, but their buyers are ignored. The shoppers for these girls and these boys and these children are rarely heard about. What are the challenges to going after the ones who are creating the demand for this industry?
That is a great question. For prosecutions or investigations, it's really difficult from the very beginning to even get a solid case because you're dealing with so many vulnerable victims that once that business shuts down or once they don't have that home anymore or whenever the person they're living with has been arrested or being asked questions, they disappear, right? And so we have to have more training, more resources, more shelters, more places for them to be able to feel like, hey, I can stay and take part in this investigation. I can stay and take part in this prosecution and see it all the way through. Because from the time the investigation starts to the time we go to trial and you need this victim, it's a huge chance that we have lost her or him at that point. Right. And so for them to even cooperate from the very beginning and feel comfortable and supported by the three, detectives who've talked to her, the prosecutor, a victim advocate, someone who's giving her resources, and seeing all these people, if we can't even get them to, talk to us about what's happening to them in that moment, how are we ever going to be able to get them or any witness around them to talk about the bigger players as well? So that's a huge challenge when it comes to investigations and prosecutions.
Right. Thank you.
And I would just add that in regards to thinking about the buyers or folks who are pushing this on the labor trafficking side, it's really woven into so many parts of our economy, right? Into our businesses, into our structures. It's not by accident that so many victims of sex or labor trafficking are isolated in many ways, or that there are so many ways to utilize technology to hide these activities. And I would also say something that we saw when we were doing our data report was that not just here in Kentucky, but across the country, what we're seeing is like a disparity in ways that we have sort of tried to proactively address trafficking investigatively and going after potential buyers when we don't have an identified victim, and using resources, significant resources, when in some cases no victims are actually identified, because it's hard when you cast a really wide net that way in technology-based platforms. But then how do you then transition that and do more focused law enforcement efforts that do have identified victims, where you're then able to sort of help them access services? And so I think there's still some questions about what the data is showing us really works, and then those natural challenges about technology and isolation.
Okay, thank you. Representative Sharp.
Thank you, Mr. Chair. I appreciate this presentation today, and this is as a father of two daughters, this just really gets me mad. But I do have a question that's kind of directed toward the Catholic Charities, and as a Catholic, this is something that has concerned me. Over the past 3.5 years, Catholic Charities has assisted in bringing over 20 million plus illegal immigrants across the border. And as of this weekend, Senator Tishner, there was a report out that said that 330,000 of that were children that the government has lost complete accountability of. They don't know where they're at, they don't know what they're doing, and at least a great portion of that they're being trafficked. These kids are being trafficked. So my question comes to, what type of controls does Catholic Charities have in place for the kids they bring across the border to track and make sure they're not being trafficked?
So I can't speak to the larger Catholic charities of other states, but in Kentucky, the Catholic Charities of Louisville, we don't bring people over the border. We have migrant refugee services, so they work with refugees, and they work with refugee agencies to bring those identified refugees.
Okay, you're operating under the umbrella of Catholic Charities. At some point, there needs to be a head there that can control and coordinate all this.
Right, so Catholic Charities are individual nonprofits, but I think certainly there's a larger immigration issue. Human trafficking that happens connected to immigration is a much smaller portion over the overall issue of immigration. And the services that are provided in Kentucky to folks who may be foreign-born survivors of trafficking were trafficked in the United States, right? And they arrived in the United States through a variety of means. I think there's this belief that folks who are here who are being trafficked are all undocumented.
So the answer is there's no controls.
Many of them are here with legal status. They're sponsored by their employers, and their employers exploit them.
The answer is there are no controls through Catholic Charities right now, because it seems like you're not coordinated.
It's not the purview of Catholic Charities to control immigration. I'm not going to speak on behalf of Catholic Charities today, but that is federal law. Catholic Charities is a nonprofit service provider.
Yeah, they're operating as NGOs to bring these illegal immigrants across the border.
That's just not true.
All right, what is true?
The illegal immigrants, the people that are crossing illegally, first of all, the modal category or visa overstays, they enter the country legally. People that are crossing illegally are crossing whether or not Catholic Charities is there. Catholic Charity, and first of all, the people that are crossing, I've been to the border 3 times in the last 15 months. I've talked to migrants, I've talked to Border Patrol, I've talked to people that are assisting in Mexico and in Texas. The people that are crossing, the vast majority of the people come and they turn themselves in as asking for asylum status, which is overloaded. There's the what we can do in Kentucky. This is a federal issue, right? So addressing the immigration system is something that's done at the federal level. So when Catholic Charities or these other organizations in Mexico and the United States assist asylees who are here under our laws, our asylum laws, which I'm grateful for, to get to a destination, to someone that they know, which is most people have someone that they know.
Doctor, would you agree then at some point that maybe there needs to be some coordinated effort to put some sort of controls in place to make sure whether they're adults or children that are not trafficked?
There is. The Border Patrol has. I talked to them. I asked them specifically about human trafficking when I was there in March. This is the border, because everyone. Okay. There's the people that turn themselves in are processed are screened for human trafficking, and because sometimes minors cross with people that are not their direct parents. Like I talked to a migrant, he said his nephew or something crossed and they were separated, which is following Border Patrol's policy. And I said, you need to go on to your final destination because he wasn't directly related, right? So that doesn't mean that this idea that every one of the unaccompanied minors is being trafficked is the data. There's just not data out there. Like, it's kind of used to like frighten people. And there is trafficking. I've talked to people that were trafficked at the border. So one of the frustrations of Border Patrol and of the aid workers is that because we don't have enough legal pathways for migrants, Border Patrol then is caught up dealing with a humanitarian crisis and not able to expend their resources on human smuggling and drug trafficking and human trafficking. And so enabling for more people to come enter the country legally is an immigration solution that has to happen at the federal level, right?
Well,
So
I agree with.
Excuse me, I'm sorry. I'm going to cut this off.
Yeah.
We're not going to get into a long, lengthy discussion on immigration. We're talking about the services that Catholic Social Services provides, and whether or not somebody is vulnerable is probably the point. So I'm going to leave it there. Thank you. I appreciate the discussion. We do have two more questions. Senator Funky Fromeyer, if you can keep it real quick.
Yes, in fact, I just wanted to acknowledge great thanks to Representative Mosier, but also Representative Stephanie Dietz brought forward the sex trafficking dolls. And just last week, we were able to acknowledge the great work from our Commonwealth's Attorney's Office in Coleman, and thank you for what you're doing. I'm sorry, Roa Zakaria. I just want to offer just great things, and I did get to meet Charity, and so excited that we have a four-legged that can quadruple down our efforts to attack this issue head on. So thank you, and thank you, Rep. Mosier, for bringing this to us today. This is such a health crisis.
Thank you,
Of
Senator.
course. All right. Thank you. And last we have Representative Camuel.
Thank you, Madam Chair, and thank you all for all of the information that you provided today. It's a lot to take in, and it's heavy. I just have a brief question, and it's really because of the testimony from Ms. Flores. Thinking about young kids and people, her situation being atypical. Are there model programs out there to help the people who are in our schools, K through 12, to recognize atypical signs of trafficking or issues like this? And if there is that something you can share with us so that we can know what to share back to our districts?
Sorry, you can go too.
So yes, the answer is yes, there are. At the national level, the Department of Education has some really helpful webinars focused on educators, and those are easily searchable online. Also, the Office on Trafficking in Persons through HHS has funded what they call the H-type grants, which is funding for prevention education to be used by school districts, utilizing a prevention education curriculum, and it builds capacity. So maybe Kentucky, one or more school districts, could decide that we're going to invest in making an application for that sort of funding to make some more robust prevention efforts here. Love 146 is not a number curriculum. It's being used in several states for that programming with specifically school districts. And I know Amy can speak to some other prevention education that they're doing through Catholic Charities.
Right, so we do not a number through Love 146, and then My Life, My Choice. And then also I Am Empowerment, and that's actually specific to males. And so we have actually done My Life, My Choice several times in schools, and is something that we're actively working on and trying to get into more school districts because we are seeing the importance. It's evidence-based to be able to identify that before a youth takes this curriculum, what their knowledge is, and then at the very end, how much more their knowledge has increased on trafficking, on the tactics, and then the resources for them. So, and we've been able to do it in we have a lot of success in residential programs, but we do think that it's very important to be able to also put out in our schools.
Thank you very much. If that's information you could share with, that would be phenomenal. Thank you.
Thank you. Good question. And I just want to remind members and anyone who is listening or who was here today that all the meeting materials are online, including the great data set that has been put together by the task force. So thank you so much for your work prior to today. Thanks for coming and sharing all of your work with us today. And I think that we've got some maybe good ideas and continuing conversations. So our next meeting is September 25th And since we have no further business, I move for adjournment. Thank you.